Hello and welcome to everyone joining us today. My name is Joanne Joseph. I'm going to be the facilitator of the session today. It is, of course, brought to you by Sunday Times Connect in partnership with Servia and SA Heart. Now, it is the 29th of September, as you're well aware, which means it's World Heart Day, and it's being commemorated in the broader context of Heart Awareness Month. Heart health is looked at annually on this day in much the same way all over the world, with the aim of educating people worldwide and preventing the spread of heart disease. But this year, we know the stakes have been raised. There's been a major new factor which has prompted us to think differently about the vulnerability of the human heart, and that is, of course, the advent of COVID-19. Now, this multi-organ virus has meant patients with underlying conditions have been put at significantly higher risk. And today, we're looking more specifically at an overlooked but common heart condition known as angina. Perhaps many of you have heard of it, but do you know what angina actually is? Do you know whether you, a friend, or a relative might have it? And if so, how it can be treated? Now, the good news is we're living in a time when great inroads have been made into the understanding, treatment, and the prevention of coronary disease. And we're joined by two experts today who are going to help us unpack this disease. So you may see them right now. I'm going to start by introducing Dr. David Jankalo. Thank you so much for your time today, Dr. Jankalo. On the other side, Dr. Butao, and I'm going to be introducing him in just a short while. But let me start with you, Dr. Jankalo. We know you are president of the South African Heart Association, better known as SA Heart, and you are, of course, a clinical cardiologist based at the Netcare Linksfield Clinic since 2000. Dr. Jankalo is also a friend of the College of Medicine of South Africa, fellow of the American College of Cardiology, and fellow of the European Society of Cardiology. Of particular interest to him are disruptive technologies in medicine and cardiology. Dr. Jankalo is going to welcome our viewers next. Thank you, Doctor.
Thanks very much, Joanne, and thank you to all your viewers and for the opportunity. Appreciate it.
All right. So do you want to just give us a slight intro to what we're going to be talking about today, Dr. Jankalo?
Okay. So today is World Heart Day, and 29th of September, and we've had for the last month a campaign called Angina Awareness Campaign in partnership with the European Society of Cardiology and sponsored by Servia. And I thank Dr. Butao, who's the head of our education committee of the South African Heart Association, for having taken the lead in this endeavor. The whole aim of the World Heart Day is to bring awareness to heart disease, which is the biggest killer in the world. And it kills up to 250 South Africans every single day and up to 50,000 people worldwide. Claims nearly 80 million lives globally every single year. So we want to bring awareness to the symptoms of heart disease and what the public should be concerned about. We don't want to create panic, and I think that's what we want to delve into. Can I talk a little bit about the South African Heart Association?
Yes, you're welcome to do so.
So SA Heart represents the professional interests of everybody that works in cardiovascular medicine in South Africa. And our mission and vision is to ensure that there's adequate cardiovascular care for every single citizen of beautiful South Africa. And our association is founded on a number of pillars: membership, education, science, and advocacy. And that's what we concentrate our efforts on. And so we've fortunately been engaged with the Ministry of Health recently to advise them about heart disease and COVID. We developed a position statement with respect to heart disease and COVID, and we've been put onto the Ministerial Advisory Committee. But what is more important is that the ministers asked us to be engaged about non-communicable diseases going forward. And as I said, heart disease is the biggest killer in the world. But perhaps I could hand over to my friend Dr. Butao.
Dr. Budal, I was going to introduce you in just a short while, but now's as good a time as any to just tell our viewers a little bit about you. Dr. Martin Dawanda Budal is the gentleman of whom we speak. He's also a cardiologist, and Dr. Budal began his career at the Eastern Cape Health Department in 2004. He did a stint in private practice before becoming a medical registrar, and later became a cardiology fellow and a senior registrar at the Western Cape Health Department. Then he headed up the clinical unit of cardiology at the PE Provincial Hospital a few years later. Dr. Budal has returned to private practice. He's now also a sessional cardiologist. So welcome to you, Dr. Budal. Would you like to quickly add anything to what Dr. Giancarlo has said?
Thanks very much, Joanne. The cardiovascular disease really is the kind of number one killer, and has kind of fallen a little bit to the wayside in light of the current COVID pandemic. But I think World Heart Day is a good opportunity as any to remind the nation and people out there that, cardiovascular disease is something we need to be aware about. There needs to be increased awareness about the symptoms that are associated with cardiovascular disease, and that there are treatment options that have been proven and are available widely within the borders of South Africa for people to get relief from cardiovascular disease.
All right, thank you very much for that, Dr. Budal. So before we get stuck into our discussion, I find it always helps to have a visual representation of what we're about to speak about. So let's give you a little bit of context as to what we'll be exploring in the next few minutes. Take a look at this. So I hope that gave you a clear idea about what it is we're going to be speaking about in the next few minutes. I'm going to jump in there to just get to the heart of what angina really is about. And perhaps I'll start with you, Dr. Giancarlo. What exactly is angina?
Angina is a syndrome. First of all, if I could just explain to you and your viewers that the heart is a pump. Pumps blood and oxygen. You can see on the screen behind me the heart pumping. There's a big pump, the biggest artery in the body, called the aorta, that comes out the heart. It arches in the chest, and that is the conduit which basically supplies oxygenated blood to all the tissues and organs that require it. But the heart requires its own blood supply, and there are three little arteries that supply your heart muscle, which return the myocardium with blood and oxygen. If you suddenly block off one of those vessels, you have a heart attack, which we term a myocardial infarction. But as people get older, particularly if they've got risk factors, they're smokers, they're diabetic, they have high cholesterol, hypertension, sedentary lifestyle, poor diet, the more risk factors you have, the more chance you have of getting a fibrofatty degeneration of blood vessels, which may clog the vessels up. And once the vessels are blocked or narrowed, what we call stenosed, that person, when they exercise, the heart muscle would require more blood and oxygen during exercise at times of increased demand. But there may then be an imbalance between supply and demand for blood and oxygen at that particular time. So angina is a syndrome where people complain of chest discomfort with physical exertion. It may occur with emotion or stressful emotions as well. So there's many causes of chest pain. there's many layers from the skin outwards to the heart inwards, and each one of those layers could have some kind of chest pain syndrome. But we're particularly concerned when patients come to us to say that they're getting a burning discomfort in the chest when they go and exercise, and that may well be indicative of angina. So angina is a syndrome.
Right. Dr. Patel, just give me a sense of this. Dr. Jankler has spoken to us about some of the symptoms there, but we've got a really good question from one of our viewers today, and I do encourage you to use the live chat function because there's some really excellent questions coming in, and if you have any for the doctors, this is the best way of putting the question to them. You just send it through on the live chat, and I am able to get that question to them. Gloria asked Dr. Patel, how can you differentiate the normal chest pain from the heart attack chest pain? And that's a really good question because I know someone close to me mistook a heart attack for indigestion.
So it can be quite difficult, but in general, the typical description that's given is that it's a pressure, tight sensation that's experienced. Some people experience it as far up as the jaw or neck. Others, it goes into the back. With others, it even radiates into the arms and causes a numbness. So it can have a variable presentation, and not everyone gets the same symptoms. But the general description is that of a crushing or a very severe compressing chest discomfort that becomes on suddenly and becomes persistent, and is often associated with shortness of breath, nausea, a sudden rush or activity of the bowel. And the person may end up feeling quite faint or lightheaded. So there's a very variable presentation to it, which is why we generally will say when there is doubt, one should seek medical attention quite rapidly.
Is there a significant difference, Dr. Budal, between the kind of symptoms that men and women experience when they have angina?
Strangely enough, there is. A lot of the women patients that we come across do express sort of a far less descriptive symptoms. Some will describe severe breathlessness, or just I feel unwell, and this sensation is just getting worse with a deep sense of doom or impending death, and that's the way the women folk will present. So it's not always described, and that's the key. That just because someone is not describing pain does not mean that there isn't actually a problem that's related to the heart.
Dr. Jankalo, I can well see that this might be confusing for patients because you distinguish as doctors between stable and unstable angina. What is the difference between the two?
Okay, so if you look at the screen behind me, there's a depiction of a man with angina. He's been sitting in the restaurant. He now walks up the stairs, gets a tightness, heaviness, discomfort, and as we both said, people describe it variably. Stable as angina is usually predictable symptoms. So the person knows that he has this disease, but he gets a discomfort, say perhaps every morning when he walks up the hill to catch the bus. He has to stop and rest and perhaps take one of his medications for relief. Unstable angina, by definition, is any anginal syndrome or condition that has changed or worsened. So we really are concerned about the patient who comes to us and who says to us that my pain is coming on with less physical exertion, it's much more severe, and it's taking much longer to go away, and it's much more frequent. And that's the kind of patient that we really have to be very, very careful with, because when they tell us that kind of history, they could be heading for an acute coronary syndrome, such as a heart attack or a myocardial infarction. So we take that very, very seriously. So that's
Sorry to come in there, Dr. Jankler. I was just going to ask you, is it inevitable that if you're experiencing these angina symptoms, that it will invariably end in a heart attack?
No, not at all. Many patients live very, very well. The other thing is in 2020, patients who come to us with chest discomfort, when we investigate them, we would take a careful history and examination. We would do an ECG. We would then do a treadmill test. And on the treadmill test, we're looking for ECG signs that the heart muscle is indeed devoid of blood and oxygen under stress. We would then decide on the appropriateness and bearing and considering all the clinical factors as to whether we would treat the individual medically or whether we would perform an invasive coronary angiogram to get a roadmap of what the vessels look like. So you can treat this condition medically, and modern medical therapy is very, very effective. We can delve into that just now. In the 1970s, when they developed angioplasty, cardiologists then, for years afterwards, the phrase ballonetics was coined, because the cardiologist would do an angiogram and he would go after every narrow vessel. Now it's a lot more complex, because those with stable coronary syndromes can be treated medically, and angioplasty and stenting doesn't necessarily save lives in that instance. But we have to consider all the factors. Angioplasty and stenting, opening up the clogged vessel, saves lives when the patients are unstable. But obviously, if you take a trial of thousands and thousands of patients, and there's been a really important study called the ischemia study recently, which randomized patients with stable coronary disease. They all had evidence of an imbalance of a reduction in blood supply to the heart muscle under stress, which we term ischemia, and they all had blocked vessels, and they were randomized to either medical therapy or angioplasty and stenting, and the outcome at the end of a number of years was exactly the same. There was approximately a 25% crossover of the patients in the medically treated group to the patients that were so-called revascularized, that underwent balloon angioplasty and stenting. So obviously these patients can be treated medically in the first instance, but if symptoms are ongoing and intractable, that's when we would consider changing tack to a more invasive stance.
All right. I'm going to pick your brain in just a short while, Dr. Jankler, a little bit more on that surgery and what exactly it entails. So let me bring you back in here, Dr. Budau. There's some really good questions about hereditary inheriting of these kinds of diseases, or angina more specifically. And we know Dr. Jankler actually touched on that a short while ago, but perhaps you can just expand on that for me a little bit. What is it that you need to keep in mind if your parents have had some kind of coronary heart disease, diabetes, or any other diseases which may play into your risk factors for angina?
So if you have a first-degree relative, the most important of which are your immediate parents, and then it's uncles and aunts, which are second degree, as well as grandparents. If any of those relatives have had, if they're male, coronary artery disease younger than the age of 55, and if they're female, they've had a heart attack or proven coronary artery disease below the age of 65, those people have what's called premature coronary artery disease, and that tends to run in families. Unfortunately, it's not an absolute thing. It's just if I'm seeing you as a patient and you tell me your dad, your uncle, your grandfather died below the age of 55 from a heart attack, and if your grand or aunt or mother died below the age of 65 from a myocardial infarction, then I will look at you with a sort of a closer eye and a sort of finer tooth comb, a fine tooth comb, as compared to someone who has no family history whatsoever. Unfortunately, the issue with hereditary component of coronary artery disease as a risk factor is we have nothing to measure it. It's just something we need to keep in the back of our minds and be aware. There are families where all of the males demise before the age of 50 from coronary artery disease, and in those patients, when someone starts getting symptoms even in their 20s and 30s, we have to take it quite seriously.
We had quite a good question from Sibunda, who said to us, I have hypertension and diabetes. I'm taking medication and have both under control, but my father died of heart disease. Should I be worried? Dr. Budau?
I think he requires at least a proper evaluation, even though his risk factors are under control. He requires a thorough evaluation to ensure that he hasn't reached a stage where he has what we call concealed or occult early coronary artery disease. Dr. Jankler already spoke about some of the tests we do, the non-invasive one and the most commonly available is what we call an exercise or treadmill test, where we will attach an ECG to your chest, and under a very strict and organized fashion, we will let you exercise and see if at any point in time during the duration of the exercise you develop an ECG abnormality, an abnormality of your blood response, or symptoms suggestive of chest pain during the exercise. And that will give us a good non-invasive clue as to actually whether or not you're starting to develop problems with your coronary arteries.
Dr.
So
Vidal,
to answer the question.
apologies, just continue.
No, I was saying to answer the person who's asked the question, they certainly require a full evaluation because they have at least 2 risk factors if they are diabetic and hypertensive, despite these conditions being under control.
So interestingly, Silo asked a similar question. I want to know more about chest pains and how diabetes affects them. How significant a factor is diabetes in relation to angina, Dr. Vidal?
So diabetes is a significant contributor to developing coronary artery disease. And unfortunately, if you've had long-standing diabetes, it can also be a confounder because one of the complications of long-standing diabetes or poorly treated diabetes is that it starts to affect the nerve endings, both to the skin, but also to the internal organs. So your perception of pain as a diabetic may be actually abnormal. So patients that are diabetic may not describe or experience typical chest discomfort or pain. They will report excessive breathlessness with exertion, which is what we call an angina equivalent. It's someone who's developing angina, but is not appreciating chest discomfort as pain, but they in actual fact have angina. So the diabetes adds a slight confounder in terms of how patients can develop symptoms when they do have angina.
Dr. Giancarlo, in terms of prevention, which we all know is much better than cure, how does one go about designing an exercise or dietary regime looking after one's heart in a way that makes you, puts you far less at risk for angina than you otherwise would?
I absolutely agree. We want to prevent this disease. And as we said, there's modifiable risk factors and there's non-modifiable risk factors, which is your genetic makeup in the family where you came from. You can't adjust those, but you can control your modifiable risk factors. So, the advice is for the entire population not to smoke. Smoking and high cholesterol are the worst 2 factors. But the risk factors don't add to one another. They multiply one another. There was a study, it was called InterHeart a number of years ago. It was a case control study of survivors of heart attacks. That was 52 countries and thousands of patients. And they asked the question, why did these patients have heart attacks? And the common garden risk factors, smoking, dyslipidemia or high cholesterol, hypertension, diabetes, sedentary lifestyle, lack of exercise, all came out paramount. But the 2 most important risk factors were smoking and elevated cholesterol. So there's nothing mystical about this. So everybody should, and you talked about the person on the webinar said, should he be worried? There's no reason ever to panic or worry. The strategy should be one should consult one's doctor and one should have a concerted approach in addressing all your risk factors. You talked about this gentleman or lady who's hypertensive. The risk of dying with hypertension is fairly low. We treat hypertension mainly to prevent stroke, but if you start adding in all the other risk factors, the risk goes up exponentially. And I think that's what we need to educate the public, that lower cholesterol is better, and particularly in a diabetic's cholesterol should be extremely low. The lower you get the bad cholesterol, the less deaths, heart attacks, and strokes. There's no doubt that lower is better. But it's controlling blood pressure, stopping smoking, dieting, reducing alcohol, increasing exercise. In terms of exercise, the World Health Organization recommends that we all exercise for 150 minutes, that's moderate intensity exercise every single week, 30 minutes 5 times per week, or 75 minutes of more vigorous exercise. And moderate intensity really is brisk walking, a little bit of cycling, playing tennis. It's not high intensity training. You know, there's evidence in Africa that up to 50% of people aren't adhering to those guidelines. And we know that people that are fitter, that increase their physical activity, have less total deaths, less cardiovascular deaths, and less cancers. And if the entire population had to adhere to those simple guidelines, a proportion of acute cardiac events would be avoided.
Some great advice there, Dr. Jankalo. Dr. Buttar, a really good question from Shannon. Can angina be cured, or is it a chronic disease that's with you for life?
So if we take the perspective that angina is a result of the narrowings or significant narrowings in the coronary arteries that feed your heart, then we can never cure the condition, but we can make it manageable. Generally, someone would have presented or come to the fore with angina because they start getting chest discomfort. And once we've done an assessment, we will generally decide either to treat that patient with medications that will relieve the symptoms of chest discomfort, or where we think someone is at high risk of or has very bad narrowings, we may opt for a strategy where we do coronary angiography, where we actually look and evaluate the coronary arteries to see where the narrowings are, and if we cannot intervene with stents, or sometimes even something as drastic as bypass surgery to try and relieve the narrowings in the arteries that feed the heart. The symptoms will go away with the intervention, but the patient will never be cured. And I think that's a very important concept for us to realize, that it becomes an ongoing thing, that they must continue to adhere with the various medical treatment modalities that we prescribe for them to ensure that there isn't an accelerated progression.
But Dr. Buttar, are you able to continue exercising as normal once you've been diagnosed with angina? Do you have to follow a specific exercise program that the doctor prescribes for you?
So generally, on medication, we will then prescribe or tailor an exercise program that we would recommend for you to adhere to. We definitely would not recommend and would advise against very high intensity activities, such as those who participate in competitive sports, people who want to do ultra marathons and such extreme sporting activities. Those would not be recommended. But your run-of-the-mill activities, like a little bit of cycling, like Dr. Jankalo spoke about, playing tennis, water sport. The idea of treating you for the angina is to enable you to actually return to those normal activities that you would like to enjoy without any discomfort.
Right. So, Dr. Jankalo, I mean, one would hope it doesn't get to the stage where you are required to have some sort of invasive surgery to be able to deal with the program. But I know that that is the reality for many people all over the world. Would you just talk us through, in layman's terms, the process of what happens when a patient comes in presenting with very serious symptoms, like a heart attack or multiple heart attacks, for example, and you get going with that process of deciding how exactly you're going to treat them and whether you're going to consider surgery for that patient.
Okay, so when a patient has a heart attack, you just imagine, I told you about this process called atherosclerosis, this fibrofatty degeneration of vessels. If you look at the screen behind me, you can see an artery over here with a plaque, and there's a thin cap, and underneath it, the plaque has cells that are laden with fat and cholesterol. The danger of the plaque is that at some point in time it could rupture or fissure or split. And when it ruptures, a clot forms on top of it and blocks the vessel off. So just an analogy, if you're driving your car in the road where you live and they've retarred the road, you come back a week later, there's been some earth movement, there's now a crack in the tar. When the surface of the plaque cracks, that exposes the underlying elements to the constituents of blood, and a clot forms on top of it. The first aid is to get that vessel open as quick as possible, because time is muscle. The treatment of these acute severe syndromes, such as a heart attack and stroke is the same. The quicker you get the vessel open and restore blood flow, the better the patient does, the better the outcome is. And we generally prefer a strategy of balloon angioplasty and stenting, but there are drugs which we've used for many, many years called thrombolytics, which we would decide on in certain instances. They are clot-busting medications. But when the patient comes to my hospital where we have a dedicated cardiac catheterization laboratory and staff that are on call 24 hours a day, 7 days per week, 365 days per year, we would opt on a strategy of mechanical revascularization, if at all possible. When the patient...
Sorry, just break that down for me, please, Dr. Jankalo. What is that mechanical process?
That's using a balloon, is doing the angiogram, getting a roadmap of what the vessels look like, identifying what is blocked, passing under vision a guide wire across the occluded vessel, opening it with a balloon, and then putting in a stent, which is a scaffold which keeps the vessel open much longer than if you'd used a balloon by itself. When they developed angioplasty in the 1970s, we know that about 30% of patients would come back within 2 years with restenosis. Once you put the stent in, which is the scaffold, and now the modern stents are coated with a drug that acts at the cellular level to prevent this regrowth of tissue, which we call restenosis. So that's what we would do acutely. Also, when the patients come in, the first medication that we would give is aspirin, because aspirin saves lives in that instance. We would give an anticoagulant, such as heparin or something called Arixtra, we would give high-dose cholesterol lowering. We probably would give a medication called a beta blocker. And then we would decide urgently to take them to the cardiac catheterization laboratory to open up the vessels, which we call revascularization. That's what we would do acutely. We want to stabilize, we want to open up the vessel, restore flow, and get over the emergency setting, and then decide on a strategy moving forward.
And Dr. Patel, how routine have these sorts of procedures become these days?
They have actually become quite routine. And I think just to add to what Dr. Jankalo said is that it's important to note that this reopening of the occluded or blocked vessel is done percutaneously. We put a special drip into either the arm, into the leg, and through that special drip, we go with specialized equipment that we're able to navigate up the blood vessels, get to the heart. Then we use special x-rays to see where the blockage is. We inject a little bit of dye that also enables us to see the roadmap, as Dr. Jankalo said, of where the arteries are. I don't know how well this will project, but I'm holding in my hand a little glass container here. And that little metal thing you see in there is what a stent looks like. That little metal thing that's inside the bottle. And we're able to implant these little things through these specialized plastic pipes that we are able to navigate up the body from the arm or from the leg all the way to the heart and deliver these devices to reopen and ensure that a blocked vessel remains open. Then there's specialized medication, of course, that the person needs to take going forward to control these risk factors and make sure that the likelihood of recurrence of these blockages is very, very low. These procedures have become quite routine, but the sort of the limitation of the constraint at the moment is the number of cardiologists that are actually available countrywide. There are areas that are very well serviced with cardiology services and cath labs. That's a specialized piece of equipment that we use to do these procedures, as well as the dedicated staff that are available. There are vast or big areas within the country that don't have any cardiology services at all in certain provinces. So that's where the sort of the constraint lies at the moment. But the skills and expertise are certainly quite widely available within South Africa now.
All right, that's good to hear. I must ask you a question about the prognosis, Dr. Patel, for patients who've undergone these kinds of operations, whether you've had a stent put in or you've had a triple or quadruple bypass. what's the prognosis for how long you live and what your quality of life will be after the operation?
So the quality of life, generally, if you've been able to salvage the heart muscle nice and early, the prognosis is actually fairly good. But I will say that this is provided that you also then continue to take the medication we prescribe going forward. And most importantly, if you're a smoker, to stop, not reduce, but completely stop smoking altogether. That way, you definitely improve or reduce the likelihood of you having further events within a very short space of time by almost 80–90%. But it's incumbent that, one, you stop smoking, and two, you take all of the medications that we prescribe to try and prevent, obviously, a recurrence. The biggest stumbling blocks I see in clinical practice at the moment is that people who are smokers are quite reluctant to stop altogether. They think cutting back makes a difference. If I was a 20-a-day smoker, now I only smoke 5 a day, then I'm safe. Actually, you're not. Unless you stop altogether, you're not making any difference whatsoever in terms of your outcomes from a cardiovascular perspective. And if you are someone who's diabetic and hypertensive, making sure that those conditions are now well controlled definitely reduces your chances of having, accelerated problems going forward.
Dr. Budal, what about alcohol consumption?
So that has no absolute cause and effect relationship with regards to cardiovascular disease. We know that excessive drinking of alcohol in general is detrimental to your health, not only to your cardiovascular health. It adds or complicates the control of your hypertension if you are hypertensive. The only form of alcohol that has been studied and has any sort of believable data to have some benefit is actually red wine, but when that's taken in moderation, like a glass, not an entire bottle, unfortunately, on occasion. So that is something to consider and to note that there is no benefit to a specific type of alcohol in terms of protecting you or preventing you from having cardiovascular disease.
Dr. Jankler, I think you wanted to add something there.
Just a few things. Firstly, the lifestyle adaptation is probably one of the most important things. And the only people that change their lifestyles are those that get a mindset change, that I'm lucky to have come through this. I could have possibly died. I want to be well. I need to take some responsibility to help the doctors to help me. Those are the people that stop smoking. A lot of the patients that we see just say, I know, and never do anything. So the lifestyle adaptation is as important as the medications. And it does frustrate us when you see somebody who's not willing to change their lifestyle, but at every turn they're consulting us urgently and sometimes even in the middle of the night, and you have to do repeated procedures on them. So people have to take responsibility.
We've got quite a good question from Lorraine, who says, after angioplasty, 5 stents inserted and 3 arteries opened by rotablator, hope I'm pronouncing that correctly, is it normal to have some pain in the chest where they worked? Feeling groggy from drugs also to be expected? Who would like to comment on that? Dr. Budal?
Well, that sounds like someone who's had multiple interventions, and there's been, I assume, much work put into trying to reopen vessels that were very calcified. In other words, had very heavy calcium deposits. That's why they would have resorted to using the piece of equipment you referred to, and you did pronounce it correctly, the rotablator. That's a tool that we use to work in very hard calcified arteries, which we otherwise are unable to open successfully and reestablish flow in. So I'm working on a presumption here that it's not normal to have chest discomfort, especially the angina, after a successful procedure. But sometimes it's indicative that the upstream or bigger vessels have been addressed. But unfortunately, there's nothing you can do about the really small downstream vessels, what we call microvasculature, that is now permanently damaged from long-standing coronary artery disease, and unfortunately, that will not completely resolve. We are able to manage and reduce the burden of discomfort, but we may not be able to completely, solve or eliminate that patient's pain. So without being exact here, I don't think it's normal to continue having pain, but it's usually indicative of residual problems with the arteries.
Dr. Janklow, what's your take on that?
Often when we do a percutaneous intervention, angioplasty and stenting, for a few hours afterwards, patients could have some chest pain, which is due to stretch of the artery. So we would be concerned about patients who've had a major intervention who continue to have chest pain. The other thing is that we're always vigilant that where we've put catheters into the heart and balloons and wires and stents, that if a patient has chest pain afterwards, one thing which can really happen is that there can be a tear in the artery or a rupture, and you can get fluid and blood around the heart. And so we would have a low threshold once the patient's in ICU who has ongoing symptoms soon after an intervention to do a cardiac ultrasound, an echocardiogram, just to make sure that there isn't such an injury. It's very rare for that to occur, but it may occur. But the patient shouldn't continue to have chest pain for long periods afterwards. Just getting back to the intervention, if I could just say one thing. The patient, if you look at what are the factors that kind of distinguish the prognosis of patients with angina and coronary artery disease, it's the number of vessels that are involved and the state of the left heart function. So if the left heart function is poor and the patient has triple vessel disease, they have a worse prognosis, and those patients should actually be referred for bypass surgery. The patients with single vessel disease have a similar prognosis to, and with normal heart function, have a similar prognosis to the general population. And then there's another factor, it's the degree of muscle that possibly is in jeopardy when that patient exercises as well. So those are the factors that we will take into place. Sorry to interject there.
No, not at all. It was good to hear what you had to add. Dr. Patel, let me ask you this, because this is something that I had heard a doctor say that was repeated to me. And it was about some of the hereditary factors in regards to race or phenotype. And I just noticed that neither of you had mentioned that. Is there a significant difference in the size of arteries among people of particular types of racial heritage or phenotypical heritage that results in certain groups of people being more susceptible to angina than others?
I don't think it's related to the size of the arteries, but we do see certainly that certain ethnic groups do have a higher prevalence of diabetes, for instance, and blood pressure, and a preponderance to develop coronary artery disease much early on. Within the Indian community, there's a very high prevalence of diabetes, and then when that then progresses to then developing significant coronary artery disease, it seems to be quite an aggressive form. And similarly, within the white Afrikaans community, particularly of Dutch descent, there are certain families where they, from a very early age, they have phenomenally high levels of cholesterol, which require early intervention. And without it, they also tend to end up with very, very early and aggressive coronary artery disease, which can be quite difficult to manage.
Right. Dr. Janklow, a question from John. What role does inflammation have to play in the buildup of cholesterol in the arteries?
That's a very good question, because
I think we might have lost you there for the moment, Dr. Janklow. Can I throw that to you, please, Dr. Patel, until we restore our connection with Dr. Janklow? Let me just see. Dr. Janklow, are you back with us for the moment?
Can you hear me?
Yes, we can hear you. All right, I'm going to leave that question with you then. The role of inflammation in the buildup of cholesterol in the arteries.
As I said, that's a very good question. Inflammation is really part of the whole process of atherosclerosis. That if you just look at the biology of what happens to the vessel, just remember that our blood vessels are not rigid pipes such as the plumbing in the wall. The arteries are organs. They have multiple layers. They respond to cellular mediators. They contract and they dilate. And elevated cholesterol and smoking would damage the lining of the vessel. The cholesterol would then get into the vessel, and that's a highly inflammatory process. Now, we know that the cholesterol medicines, the statins, are actually anti-inflammatory. We call that pleiotropic. There have been trials in the recent years using very sophisticated anti-inflammatory drugs, which are not yet available, which have shown a difference. As all these patients should be on aspirin, which is anti-inflammatory. I just might actually add for your audience that patients, it used to be thought that patients with a hodgepodge of risk factors, diabetes, hypertension, high cholesterol, that, oh, we better give that person aspirin. But that's been proven wrong for primary prevention. There's been 3 big studies in the last 2 years which have shown that there was no upside in the prevention of heart attacks for primary prevention of vascular events, strokes and heart attacks. But where people have had a vascular event, mini stroke, heart attack, bypass stent, blocked vessels in the leg, all those patients should be on aspirin. So we do not use aspirin for primary prevention anymore. In fact, there was actually more bleeding in the brain and more gastrointestinal bleeding.
Right. Dr. Buttar, a very good question, because this hasn't actually come up before, and I'm sure it's on the mind of many people who are watching our broadcast right now. So she says many patients are given the choice to insert a pacemaker. When is it necessary, and how does it affect daily life?
All right. So the pacemaker has a very specific indication. The pacemaker will be implanted for 2 basic reasons. The most common reason for why we would put in a pacemaker is that where someone's own electrical system, the heart does function on an electrical system that ensures that it continues beating from second to second, hour to hour. And as you get older, certain people develop an accelerated wear and tear, if I can call it that, of their electrical system. And basically the pacemaker is put in to ensure that the rhythm of the heart is sustained. In other words, you don't get to a point where the actual intrinsic activity of the heart ceases and the person dies as a result of it. So that's the main reason why we put in pacemaker. There are some more fancy devices that are now available lately that we can put in for a specialized group of patients with heart failure, where the pacemaker is put in to improve the cardiac function. And then there's a completely separate group of specialized pacemakers called defibrillators. And that's the equivalent of the big machines we've all seen in a movie where someone has collapsed, they're resuscitating them, and they're given an external electrical shock. There are specialized pacemakers called defibrillators, now implantable defibrillators, that we can put in like a pacemaker, and that small device does the same job as that big machine that's used to resuscitate a person who's had a cardiac arrest. All these devices are put in predominantly for rhythm problems, which is completely separate from the topic we're addressing today. Today we're talking about the plumbing, if you like, or the blood vessels, piping that feeds the heart, and that's a separate entity to electrical problems associated with the heart, for which a pacemaker would be the treatment of choice.
So in other words, Dr. Buttar, arrhythmia or an irregular heartbeat, should that not be a warning sign that there is some kind of angina there, or might it be a sign of something else that's wrong with your heart?
So arrhythmia may be a very unusual presentation of problems with the coronary artery disease, but generally the presentation of someone who presents with problems of the cardiac rhythm, those may not necessarily be due to underlying coronary artery disease. People who have had extensive heart muscle damage from previous heart attacks, and they have scar and poorly functioning ventricles, those they have a very high propensity or probability of developing dangerous, life-threatening arrhythmias, and those patients will have implantable defibrillators put in to prevent sudden cardiac death. Yes, that's the only sort of direct relationship that we can give between coronary artery disease and angina, which is what we're talking about today, and then the need for a pacemaker.
Right. Dr. Jankalo, this is quite a long message from Gerard, who's been listening to our conversation, watching it. And Gerard, I'm sorry to see you've had such a bad experience. Gerard says, is testosterone a recommended therapy for heart health? I'd been to see a cardiologist on a Tuesday, and he gave me the all clear. 5 days later, on the Sunday evening, I suffered a massive heart attack. My cholesterol was 5.6 and CRP 0.4, and narrowing of arteries less than 10%. I have a fairly active lifestyle, and I'm mid-40s. I went for a jog on the Sunday morning with no fatigue and had the heart attack at the end of the day with 2 blocked arteries. The blood clots were removed and 2 stents inserted. I had a testosterone injection prescribed by the cardiologist on the Wednesday, and that's the only thing that points to the blood clots. How safe is testosterone therapy, and what is your opinion on using testosterone for heart health?
Yeah, we see lots of middle-aged to older men, particularly those men who want to bulk up and to lose weight. And some of them get testosterone from trainers or other doctors. My understanding is that testosterone supplementation can lead to acute cardiac syndromes. Now, I find it unusual that this gentleman went to a cardiologist and was given testosterone. The only indication to give testosterone when the levels are extremely low. As people get older, as men get older, our testosterones decline. And but it doesn't mean that we should all be supplementing. And my understanding is that it may well be harmful. The other thing is
that's my understanding as well.
That so I think the general cardiologists would not be prescribing it. The other thing is what it's interesting, he said that he's got a cholesterol of 5.6. That's actually meaningless. It's the bad cholesterol, the LDL cholesterol. The lower that is, the less events there are. We're a member of the European Society of Cardiology, and we adopt their guidelines. And I'm on the Cholesterol Guidelines Committee of South Africa. And we've, from time to time, had to adopt the guidelines. And that every single year to 2 years, the targets become even tighter. So in LDL, there's no threshold that you can't achieve benefit. If you take all the cholesterol trials ever done and you plot the mean treated bad cholesterol versus event rate, it's a linear line. The lower you go, the less events there are. So, you know, a man like him, Gerald, who's had a vascular event, unfortunately, and I'm going to come back to what that he had a number of investigations in the cardiologist's office. I'll come back to that in a second. But his LDL cholesterol should be lowered to less than 1.8 and preferably less than 1.4. But coming back to that, we've all heard famous stories of somebody said, I went to the physician or cardiologist, I had an examination, I had a stress ECG, and I had a heart attack the next day. That can happen. That does not mean that the doctor did anything wrong at all, because the pathogenesis, the mechanism of the heart attack is suddenly that person develops plaque rupture, and that narrowing might not have been detectable before. It's just that the surface of the plaque ruptured, a clot formed on top of it and blocked the vessel off, and you can't always predict that.
So I'm going to start wrapping up, gentlemen, but I do want to come back to a question that Rodney, who's watching us on Facebook, posed, because I think many people probably struggle with the idea of going to a doctor with the potential finding of a very serious diagnosis. And Rodney says, how do I get myself checked out? Because I have some of the symptoms. I feel most of the time like discomfort around my heart area. So Dr. Butau, can you just give us some advice on, I think, what is a very intimidating environment for many people, going to, well, perhaps it's not so bad going to your GP, but going to a cardiologist and having that complicated conversation, the prospect of being put on a treadmill, you know, and having all the medical equipment attached to you and so forth, can be quite foreboding for many people who would want to have this kind of examination. What sort of encouragement can you give to our viewers who may have to have that done?
So I think you've put it quite nicely, that the starting point for sort of the initial evaluation would be the GP. The GP would be the one who would do the initial evaluation. By the time someone is needing to come and see either myself, Dr. Jankalo, or any one of my colleagues, there should have been some preliminary background examination and basic tests that would have been done by the family physician or GP, who would have said, well, on the basis of their assessment, they think this is not something coming from your tummy, the chest wall, which is usually what they would pick up quite quickly from their initial examination. And having done all of that initial groundwork, they would have then come to the decision that they felt this chest discomfort is probably angina, and you would then need to come and see a cardiologist for further evaluation. So that's the first point. Where this chest pain is new, is unfamiliar, severe, and happens during the middle, for instance, the person that whose message you read for us last, middle of a run, they've never had chest discomfort before, they get this pain, those people should go not only to they shouldn't go to their GP, they should go to the nearest emergency unit or a hospital where they can evaluated, have blood tests and an ECG to make sure that this is not one of those unstable coronary syndromes, because those actually can be life-threatening. So I think that's the approach I would recommend, that someone who's getting this discomfort on a regular basis, the initial evaluation should be with the family physician or GP, who will then take the step to say, okay, you need to have this taken further and you need to be seen by a cardiologist, and then they can be evaluated from there. But where it happens in an unstable situation, as I've just described, straight to the emergency unit. That would be the way to go.
Dr. Jankalo, we all know intellectually that's very good advice indeed, but not all of us will take that advice because of the projected outcome potentially. We're very concerned about being diagnosed with something as serious as angina or coronary heart disease. What can you say to patients who may potentially feel ill at ease in the kind of environment in which you and Dr. Budal work on a daily basis?
We see lots of anxious people. Main thing is to be friendly and reassuring. What we want to mainly do is extract fear from the patients. I saw a lady this morning who was absolutely anxious because of a fast heart rate. And all I tried to do was show that her heart function was normal, the ECG and stress tests were normal. I couldn't find anything, and she felt much better walking out. So we're not that bad, we're not that scary, but occasionally we do find life-threatening conditions. But there's never a reason to panic. Panic is not going to get anybody anywhere. We need to, if we do find something significant, we need to deal with it in a constructive, strategic way. And the other thing is explaining very, very carefully. Communication is key. That's what I find.
Really good advice and some wonderful insights from the both of you. And I thank you so much for your time today. Dr. David Jankalo, Dr. Martin Dawanda Budal, thank you so much for your insight and your educated opinion. It's really been very informative hearing from the both of you today. So to our viewers, I hope you'll be able to go out there forearmed with the kind of knowledge that will equip you to be able to spot the symptoms that have been listed and immediately consult a doctor if you or a loved one may be experiencing these symptoms and you suspect it's angina or perhaps some other form of heart disease at play. And I think what Dr. Budal has said is quite important, that if you feel it is a major coronary event that's taking place, go straight to an emergency room. Don't go home first. Don't try to wait for a few days to set up an appointment with your GP. Give it or show it the required urgency that it needs. Of course, many of you, I think, will write off the symptoms as being something less serious, but we encourage you to have that honest conversation with your doctor, with your GP, and prevention is better than cure, as you've heard. So we encourage you to address those concerns so the problem can be addressed at the onset, and so no further damage is done to your heart. I want to thank all of you who tuned in today to watch our broadcast, and I hope you are as suitably informed as I have been by the expertise of our panel. Thank you for watching, and thank you for posing those excellent questions, which have really enhanced the discussion we were able to have today. Perhaps you'd like a family member or a friend to catch up on this discussion because they were not able to watch today, and you can do that. You will find this discussion cut and podcast on the website which you had to access today in order to get to this discussion. So thank you. Take extra care of yourself during this Heart Awareness Month. Thank you for joining us. Goodbye.